What's the saturation goal for somebody who has ARDS? 95? What? That's luxury, man. You will never get 95. 88 to 90. That's the standard, right? Yeah. Now, the other question I had is related to a system. So when Jessica and Kelly were presenting, you see how the patient status is presented in the same way again and again? Do you guys in your hospitals have handoffs?
Yes.
When patient comes from the OR, patient is placed in your ICU, do you have a handoff sheet? A lot of you are raising, yes?
Yes.
You guys follow that? Incredibly important. This is what saves life. You know, you are basically communicating what happened in the operating room to now what is happening in the ICU. That's exactly what you're trying to communicate, and the way you do that, you do it in a very stepwise fashion. So systems are incredibly important. And that's why when we say patient is this much tidal volume, this is the FiO2, this is the PEEP, these are the settings, and the endotracheal tube is located at a particular point. Same way when we are doing tracheostomies and PEG tubes, you mark where is that point. And every day, same thing we will do with ECMO. Every day, Steve will come and look at the cannula position. Things are dynamic, right? We do believe in early mobilization. That's the way to improve critical care. But along with that comes that you have to pay attention to detail. So if you guys don't have a sign-off sheet in your ICU when somebody is coming from the emergency room, it's time for you to introduce that. Systems is what saves lives.
How do you cure those patients?
Come again?
Always.
What are those patients cured?
Yes.
Good.
They're all cured.
Pergula's on that.
Basic question.
Yes.
You said our goal for saturation is 88 to 90 on ventilator, but in ECMO the goal is around 80. Why is there the difference?
Good question. Sometimes you have to, so on an ECMO the goal becomes 80 because what you will learn, and Steve you can compliment, I'm going to show you a patient that I just cannulated last week. After cannulation, I could never get his saturation above 75.
So sometimes that is also acceptable.
Well, it's one way to say accepted, but I have nothing else left.
But my question is, we are giving lungs a rest in ECMO and then we are happy with 80%.
Good question. The question is, should we be able to go to 80% saturation?
Yes.
There are a group of people who believe in permissive hypoxia for that reason. There's no clear data.
Okay. Next, we'll go through pressure control ventilation and various modes that are available on the ventilator for pressure control ventilation. First question, though, is why would we use pressure control ventilation and what are the indications for that? Increasing airway pressures, like we talked about, if your plateau pressure is starting to go above 30 centimeters of water, we should consider switching to pressure control so that we can control that. To obtain lower pressure, you may have to accept, though, a lower tidal volume or a lower PEEP. We may consider pressure control ventilation if there's poor oxygenation. We're more able to precisely control the mean airway pressure by lengthening the inspiratory time in pressure control ventilation compared to in volume control. And then lastly, patient comfort, and I think this is something that we don't consider sometimes, is that pressure control is much more comfortable than volume control for the vast majority of patients. And so if your patient's not tolerating the fixed flow that we set in volume control, pressure control has a variable flow, and so it is more comfortable for patients and may decrease asynchrony and then therefore improve ventilation and oxygenation.
What is the minimum PEEP we can go to?
I'm sorry?
What is the minimum PEEP?
Pressure control?
The minimum PEEP?
Can we go to zero?
You can. We do on APRV. We go zero.
Yeah. Generally, though, it's 5 is kind of where is the minimum for normal.
World standard.
Yeah. Yeah. But we will talk about APRV where we set 0 of PEEP and then we trap more PEEP. So in general, what is pressure control ventilation? It's where we set the inspiratory pressure or the P-insp for each breath instead of setting a tidal volume. It may be called various other things depending on the ventilator. Each ventilator manufacturer has its own proprietary names for the modes and the variables, and so it might be called P high or delta P. The breath is terminated when the set pressure is reached, and your resulting tidal volume can vary based on lung mechanics. And so we're not directly setting the tidal volume. The tidal volume is a result of the difference between your set P high and your PEEP pressures. And so we must be very careful in this mode to set our ventilator alarms appropriately, because we don't want to set our pressures, walk away for a few hours, and come back and the tidal volume has dropped in half due to the patient's changing lung mechanics. Other set variables in pressure control are respiratory rate, PEEP, FiO2, and inspiratory time. And like we talked about previously, in pressure control ventilation, the flow is not set at a set rate, it's variable. Initial settings for pressure control ventilation, when we transition from volume control to pressure control, we need to make sure we're looking at what the peak inspiratory pressure is in the volume control, the plateau pressure, and what an appropriate tidal volume is for that patient before we switch, so we know what we're aiming for. We need to determine which pressure control mode is more appropriate for your patient. There's a variety of pressure control modes, as we kind of hinted at previously. The patient requires a set respiratory rate and mandatory breaths. I would consider a straight pressure control assist control, pressure control SIMV, or PRVC, which is pressure regulated volume control. If the patient has an intact respiratory drive and does not require a set respiratory rate, we could consider hybrid modes like P-Sync, or it's called pressure control, pressure support, or just straight pressure support ventilation. And we'll dive into each of these modes as well in more detail. If your patient has severe ARDS, an intact respiratory drive, and poor oxygenation, we would consider APRV, airway pressure release ventilation. And this isn't a set list that every time your patient meets this criteria that this mode will be appropriate for them. Most of the time we're at the ventilator switching between different modes to see what would be appropriate for our patients and what would be more comfortable. So we would set our inspiratory pressure to a level to achieve lung protective tidal volumes and go from there. First one we'll talk about is pressure control assist control. This is where we set an inspiratory pressure for mandatory breaths. And if the patient breathes over the set respiratory rate, so they're triggering breaths on their own, they're going to still receive that same set inspiratory pressure. So on the side there is a graphic from Hamilton for their pressure control assist control ventilation. It shows your mandatory breaths and your delta pressure, and then that the patient can still trigger. I think number 5 is showing that triggering with that dip in pressure, and the resulting pressure control breath, which is at the same level as the inspiratory pressure we set for the mandatory breaths. Pressure control SIMV, very similar. We set the inspiratory pressure, but we also set a pressure support. So if the patient triggers a breath on their own and breathes over that set mandatory rate, they're receiving a pressure support breath, and that could be of a different delta pressure than your mandatory breath. And so we might use SIMV if we're thinking we want them to do a little more work on their own. We could set that inspiratory pressure lower than the mandatory pressure control. It's really up to the clinician at the bedside. So that graphic on the side there shows the triggering of a breath and the pressure support resulting breath in between the mandatory pressure control breath. We have pressure support ventilation. This requires an intact respiratory drive because the patient is going to be initiating every breath. There is no set mandatory rate. We set the pressure support at an appropriate amount. The tidal volume is variable depending on the patient's effort. And we use this mode for weaning whenever we do a spontaneous breathing trial to see if we are able to extubate the patient.
The pressure support is in addition to the PEEP, or it includes the PEEP?
In addition to the PEEP, so we set the PEEP, usually 5 of PEEP, and then for weaning we would have the 5 of pressure support on top. This is a hybrid mode that's available on some of the newer ventilators, pressure control, pressure support, or it's also called P-Sync on the Hamiltons. PC-PSV is on the Draeger V500s. So this is a pressure control mode that utilizes both pressure control and pressure support breaths with a matching inspiratory pressure. We set a minimum respiratory rate, and when a patient triggers a breath, they receive only pressure support breaths as long as they're breathing over that set mandatory rate, and they don't receive any mandatory breaths. So it's very similar to PC-SIMV, except that you are no longer receiving those mandatory breaths if they're breathing over the set rate. They're all the pressure support breaths. This can be used for patients that are asynchronous with the ventilator. This is more comfortable because if they're breathing over the ventilator set rate, they're able to do what they want. And then if the nurse gives a bolus of sedation medication or if they tire out, then there's still that mandatory rate that kicks in and still gives them those pressure control breaths.
So the backup is assigned,
The backup is
pressure support assigned.
a pressure control, yep. Pressure regulated volume control, or PRVC, is one of these newer modes. It's a hybrid mode as well. And this is has been very popular, at least in the area that we work in, because it is comfortable for patients. It's a volume targeted pressure controlled ventilation mode. And it functions similarly to the conventional volume control mode, except that pressure is the control variable rather than flow. So in this mode, we do not set a set flow, and flow is variable, just like a pressure mode, but you do set a tidal volume. Pressure is automatically adjusted between breaths. It's every few breaths or so, it'll adjust the amount of pressure that it's providing to the patient to reach that set tidal volume. So we can set our tidal volumes to be lung protective at 6 mLs per kg, and then depending on the patient's effort, it's going to adjust that pressure that it's providing to the patient to reach the set tidal volume. So you'll notice in the graphics on the side, it looks like a pressure control mode rather than a volume control mode. I'd like to have a couple of caveats here, though, that PRVC is not an appropriate mode for patients who have a strong respiratory drive. If they have a really high work of breathing, the algorithm will continuously decrease support, and this could lead to the patient becoming anxious, tachypnic, and asynchronous with the ventilator. Because the way that the algorithm works is that if the patient is set to a tidal volume of 300, and they're taking consistently tidal volumes of 500 or 600, the ventilator will see they're getting the appropriate tidal volume and start lowering down that support. On some ventilators, it will lower it actually right to PEEP, so they'll be getting no support at all, and your patient will be very uncomfortable. Okay, let's talk a little about APRV, or airway pressure release ventilation. This is one of our more advanced modes of ventilation. We use this to improve oxygenation, mostly in severe ARDS, and it's considered to us kind of a rescue mode for patients that we're not able to support in other modes of ventilation. We're able to increase mean airway pressure quite substantially by using an inverse IDE ratio of 10:1 or 11:1, so very extreme IDE ratios. It helps recruit atelectatic lung units with long time constants, and the goal is that 90% of the patient's breathing is going to be at time high, at the high pressure. If we're using this mode, then we must allow permissive hypercapnia with pH goals of greater than 720. This mode is very lung protective and also requires an intact respiratory drive to get rid of some CO2, as you can imagine, with those long IDE ratios of 10:1.
So when we talk intact respiratory drive, we do not give sedation.
No, in APRV, they should be not heavily sedated. Yeah.
If you sedate them and neuromuscularly paralyze them, you are subjecting them to severe inverse ratio ventilation. So it is a spontaneous mode.
But if the patient is very tachypnic because of hypoxia in ARDS, they already have the drive and everything, but how will you manage unless you sedate them?
So they're able to, hopefully with, APRV, we're able to improve their oxygenation so that they're not as hypoxic. And then hopefully that will, calm them down. They can be on some sedation, but they need to be able to initiate breaths. And, yeah.
The
And so
whole
they-
logic here, Deepak, is what do you do when somebody is severely hypoxic? Either you sedate them, neuromuscularly paralyze them in the first 24 to 48 hours, put them on a control mode. The other strategy is API. So you have to choose which one. That way you are minimizing sedation. Yeah, Raghu.
Neurosurgeons aren't going to like APRV because you lose control of PCO2, and if you have ICP issues, it will be more challenging to manage that. But it is pretty popular in some trauma units in the United States. I can't speak for India, as a way of maintaining high mean airway pressure without the deep sedation and paralysis.
APRV settings, we have a high pressure, we have a low pressure, time high, time low, and then slope and FiO2. We set the P high to the desired plateau pressure, which is typically 25 to 30 centimeters of water. If we're transitioning this patient from volume control or pressure control to APRV, we would set the P high at the previous plateau pressure. This is where it gets a little weird. We set the P low to 0, but they will not reach that 0 of PEEP because we're going to have a really, really short time low. And so the goal is to create sufficient auto PEEP, which generally we avoid in other modes of mechanical ventilation, but in this mode, we are looking to trap a certain amount in the lungs for our auto PEEP. Starting settings would include time low to about 0.5 seconds as a starting point, and then setting the time high to 5 seconds. We would observe the expiratory flow time graphic and adjust our time low so the end expiratory flow rate is at 75% of our peak expiratory flow rate. And this is something that we will be hands-on at looking at on the ventilators. It makes a lot more sense when you're actually making these adjustments and seeing how the breath reacts. The picture on the side there is showing us how we would set our time low so that we get 75% of our peak expiratory flow rate trapped and create that auto PEEP.
So time high is the inspiratory time. Or both are the
Correct.
inspiratory time.
So time high, is our inspiratory time. And then the time low is very brief, only about 5.5 seconds. But you'll see on that time high, those little waveforms showing that the patient should be breathing at that time high to get rid of some of the CO2. I talk with my hands.
We can illustrate that with the nice video we have. How are we insufflating? So the alveoli, if you look at the alveoli, they go like that, like that, like that. So we are literally relying on auto PEEP for oxygenation. That's what APRV is. But it's a spontaneous mode. Remember that.
This is a closer look at how we would set our time low and how we would determine our end expiratory flow rate and peak expiratory flow rate, and setting that at 75%. So we would freeze the graphics and then look at the peak expiratory flow rate, which there's an arrow pointing to it. It'd be negative 50 in this example, 51. Multiply that by 0.75, your 75%, to obtain your target end expiratory flow rate. In this case, you would want to set it at 38, or get the resulting 38. So here's it showing where we're measuring our end expiratory flow rate. And we would be wanting to get that about 38 liters a minute, which in this example, we are just about there.
Just go back in the previous slide.
Sure.
Okay. All right.
Yep. Peak expiratory flow rate of about negative 51, and then the end expiratory flow rate of about negative 38. Continuing on with initial settings, we would set the release rate, which is dependent on your time low and your time high, so it's indirectly set by those two variables. You can calculate the total cycle time, and then you can calculate T high. So we've got our example here where we want to have 12 of those big exhales, those big breaths per minute, and our time low is set at 0.5 seconds. So our total cycle time, 60 divided by 12 is 5 seconds, and then our time high is 5 seconds, and then minus 0.5, 4.5 seconds.
So in a patient who's breathing spontaneously, how do you sure that he's going to breathe only 12 times a day? That is my question.
Yep.
Because he's going to be
And so,
breathing maybe 60, 20, 25 times, 30 times a day.
so yeah, that's kind of what we're talking about, is that you would see on the ventilator, they're breathing 60, times a minute, and they're taking all those little breaths at time high. But then since we set our actual release rate, we set that, we can do the math on this slide to figure out exactly how many of those large exhales they're having. Yep.
That calculation for respiratory rate is only for the mandatory releases. The actual respiratory rate can be much faster if the patient is breathing spontaneously.
Yeah, and hopefully it is much faster, yeah. We'd set the FiO2. We'd set tube compensation if we need it. Tube compensation takes into account the resistance of the airways and can give a little burst of pressure to overcome that. Set the appropriate alarms, and then once we're initiated and the end expiratory flow rate is at 75% of our peak expiratory flow rate, we would continually reassess time high to maintain that ordered release rate. So every time we'd go in, we'd make sure that the lung mechanics have stayed the same, and so that our end expiratory flow rate is still set appropriately.
Tube compensation is the resistance offered by the tube, right?
Mm-hmm.
Previously, I remember sometimes they used to cut the tube right next to the mouth to decrease the resistance.
Yeah. Like,
Lot of
cut the
people
tube.
We'll talk a little bit tomorrow about how do you reduce dead space ventilation. There are many ways to reduce dead space. People have even insufflated air into the, it's called ASPR, so we'll talk a little bit about that. How to reduce the circuit to the shortest possible to augment the dead space ventilation.
I don't think it's a safe practice to cut into tracheal tube.
Yeah, but I mean,
It
if you want
works.
to reduce the resistance.
Yeah.
It will reduce resistance a little bit. It's more the radius than the length that determines the resistance, but it will make it harder to secure the tube at the correct location.
Yeah. Tube compensation is nice for, we use it, patients that have small endotracheal tubes generally.
I'm sorry, but how do you tube compensate in APRV?
For the resistance,
Yeah.
we just set the tube compensation on there, choose the size endotracheal tube, and then
There's a feature on
there's a
that.
feature on the ventilator, and it will increase that pressure. The ventilator will realize what that resistance is and increase the pressure briefly when they have that spontaneous inhalation
I see.
beyond what we have the pressure set at.
It'll ask for like the size of the tube.
Do all ventilators have this feature?
All the ones that I've seen do.
Yeah, the new
Newer ventilators have it.
Yeah, the newer ones do. The older ones might not.
So in that case, what are we supposed
Don't use APRV.
It'll be
If it's
fine
not
without
there,
it.
how can you use it?
If you have an appropriately sized endotracheal tube, 7.0 or larger, then it shouldn't be as much of a factor. It's really something for if they have less than a 7.0 tube, we would consider using it. And then, if you don't have tube compensation, maybe don't.
So the important thing to realize is these are the various different attributes. Every unit, you start using it, you will get more comfortable. That's the idea behind this entire 3-day workshop is you get more familiar with the basics. Gradually it percolates the system learns it, and then you will say, this is not as complicated as what I think it was.
And it's really good to get in the habit of looking at the ventilator screens and the waveforms, because it's very confusing, all the alphabet soup of different pressure control modes, and it can be different between different ventilator companies. It could very well be different in India from what it is in the United States. I don't know. And as Dr. Raghavedran said, these are different companies trying to market their product to get a larger market share. so I constantly am looking at the ventilator screens to make sure that I actually understand what the ventilator is doing for that patient at that moment, because if I just rely on someone telling me what their settings are, there can be confusion in the translation there. And so constantly when I'm rounding, the resident is telling me the settings, and I'm simultaneously backing into the room and looking at the ventilator to make sure that what's being told to me actually corresponds to reality. And you'll understand ventilators much better if you look at the pressure waveforms, the flow waveforms, the numbers displayed on the ventilator, both as the settings and the measurements, and really, I'm an anesthesiologist, so I spend a lot of time looking at ventilators in the operating room. But for people who don't have that luxury, spend a lot of time looking at ventilators in the ICU, and you'll learn a lot in practice.
So on the side here, we have the from Hamilton website of APRV. You'll see that where the number 2 is our time low. 1 is your P low, that's your set pressures, and then oxygenation, P high, time high, and then synchronization, we were talking about P ramp and trigger. P ramp is also called slope on some ventilators, which is how fast it rises, the slope of it. So APRV oxygenation management, your patient's hypoxic, what do? We want to ensure that our time low is appropriately set so that it is at that 75%. That would be the first thing that I would look at. You can increase your FiO2, of course. You can increase your P high, because if we're increasing P high, we're going to recruit more of the lung units. We want to still maintain lung protective ventilation, of course, but we may need to increase it in severe situations. Then lengthen T high to increase gas mixing and recruitment of the lung units with long time constants. To accomplish this, though, of course, we must realize that the respiratory rate will be reduced and it could impact ventilation. We want to assess hemodynamics as well.
For the slope you just mentioned, what should be normally the slope set in the ideal? Because it can go from 0.1 second to 0.3 seconds in terms of the slope, and it can become almost vertical. Less than 0.1, you have to doing the whole flow.
Yeah. So in APRV, yeah, we'd want it to be very short to get up to that pressure quickly. But you're right, in other patients, be longer so that it's not as fast as a flow.
The EFR is 60%, what do you do? Decrease it at 8 or more?
Yep, and so we would be, if the end expiratory flow rate you said is at 60 instead of 75, then we would decrease our time low so that we would be trapping more and get to that 75%. And so we're always making little adjustments to that if we're doing our ventilator assessments. Yep.
The Draeger ventilator has a nice feature on it that is called
Auto release.
auto release, where we set 75% on it, so each breath it's auto regulating that 75%, so it's always, the T-low is always changing, and so that's a nice feature on the Draeger, but the Hamilton med does not have that, so we're always having to go in and measure and moving the T-low around, so we're making sure we're at the 75%.
Let's talk about ventilation management. For if your patient has acidosis, you want to assess for oversedation because this is a spontaneous mode, and if they're not breathing over the ventilator and they're not taking those little spontaneous breaths, your CO2 will probably go up. We want to assess our time low to ensure that it ends when expiratory flow rate is at 75% of peak expiratory flow rate. We can increase P high because then for our release breaths, we're getting a larger release breath and blowing off more CO2. We can also increase the release rate and decrease time high so that we can have more of those release breaths. If our patient has respiratory alkalosis, we want to make sure that the patient is not hypoxemic, assess pain management. We can reduce the release rate and then reduce P high. To liberate from APRV if your patient has hopefully improved, and our FiO2 is at 30 to 40%. and your P high is less than or equal to 22 centimeters of water, and your patient's doing better, we can transition to settings that provide a similar mean airway pressure and a tidal volume of 5 to 8 mLs per kg to be lung protective. But we could also instead wean them in APRV using the drop and stretch method by simultaneously reducing our P high by increments of 2 and lengthening our time high in increments of 0.5 seconds for a gradual reduction in the mean airway pressure and to increase the contribution of spontaneous breaths to the overall minute ventilation. And so eventually you'll get to a point where you're essentially on a straight CPAP, where you have a set pressure level, and then they're still taking those spontaneous breaths on top of that CPAP level. And that would be when you're at a P high of about 14 to 16 and a time high of 12 to 15 seconds.
Or T high can be called infinity, and then you have achieved CPAP.
Yes, yep.
There's no infinity setting though.
And it's interesting when you look at APRV, especially during liberation, suddenly you look at I-to-E ratios, so what are the, sometimes they are like crazy, 1 to 13, 1 to 14, but we are liberating. And the whole reason why this is able to do it because they are spontaneously breathing. So that point is important. Like sometimes it looks paradoxical that you are increasing the I-to-E ratios.
And I want to underscore Kelly's point that there has to be trial and error in using these ventilator settings for patients. There's no way to know with certainty whether an individual patient will be more comfortable with volume control or pressure control or APRV. And I've had patients who were clearly more comfortable in APRV, and I tried to switch to conventional pressure control, and they immediately got agitated. And I've had the opposite situation happen where somebody was completely comfortable on regular settings, and when they were in APRV, they became agitated and struggling against the ventilator. So you have to not only make a decision, but be willing to watch the results of your decision and see if it's working for the patient and have the flexibility to change.
On that note, may I add that you need an adjunctive tool called jokes. Because what I have found is that particularly respiratory therapists fresh out of school, they like to make too many changes too quickly. So sometimes my job is to distract people by telling them jokes so that they give it time. So once you're set and you have achieved close to these settings, it does take time. And sometimes saturation actually goes down and you have to really tighten your sphincters and it comes back.
No, I think that point is incredibly well. No patient is, they're all different. And that's why we need a respiratory therapist. We tell them, okay, can you find so what have we learned over all these years? Ventilator dysynchrony is bad. Prevention of ventilator dysynchrony is incredibly important, especially in hypoxic patients. So the patient fighting the ventilator, all those things are not good. That's how you deal it. So in ARDS patients, when we get transfers from outside hospitals, they are on some very, very bizarre settings. So we put a clamp on the endotracheal tube. When we are transferring that patient from the transport ventilator to our conventional ventilator, because you don't want them to de-recruit. Another way to de-recruit is disintegration. They fighting the ventilator. So the whole idea behind APRV and all the different modes is what is the most comfortable mode for this patient? Because sedation and neuromuscular paralysis is not the answer to everyone. And as you all know, with neuromuscular paralysis, longer the duration, higher the incidence of neuromuscular weaknesses, right? So those things, that's what the idea behind our scenarios this afternoon is the same thing. Like, what do you do? Every patient is different. So you have to learn to figure out the basic settings, and that's why we are teaching all these different modes. It doesn't mean one is better than the other.
We'll do one case scenario with APRV, and then we'll be doing a case scenario hands-on later today. So this patient is a post-op 40-year-old male, 5'10", on pressure control, assist control mode. Respiratory rate is set at 18. Inspiratory pressure is 20. PEEP is 5, and FiO2 is 50%. Resulting tidal volume is 350 mLs. ABG is pH is 730, CO2 is 51, PaO2 is 90, and then bicarb is 24. Your respiratory acidosis. So this patient has a respiratory acidosis. Tidal volume and respiratory rate can normalize a respiratory acidosis. In pressure control, tidal volume is controlled by our inspiratory pressure. And so we see here that our ideal tidal volume should be about 440 mLs. We can increase our inspiratory pressure to achieve that tidal volume of 6 mLs per kg. We were set to about 350, and so we can increase the inspiratory pressure by 2 until we reach that tidal volume. We don't want to increase it by too much all at once, so you can cause trauma and you could end up with a really large tidal volume. And so we always increase slowly and wait and watch and see how our patient responds. Keep in mind that our plateau should still be less than 30 to be lung protective. Then we would repeat ABG, and if it persists, we would increase our respiratory rate and decrease our FiO2 in this case to prevent hyperoxygenation. Like I said, we'll be doing scenarios later today where we're going between volume control to pressure control to APRV, hands-on the ventilator. Okay. Any questions about the pressure control things that we went over?
In our ICUs, we prefer pressure control ventilation when we see hypoxia. That doesn't mean you cannot manage ARDS with volume ventilators, but we prefer. So Jess and Kelly, would you give us an idea of what are the big advantages of pressure control ventilation when it comes to hypoxia?
You can more precisely use your inspiratory time to improve your oxygenation and get a higher mean airway pressure. And so we'll see that too during the scenario where we're seeing how you set your inspiratory time to achieve the best tidal volume and mean airway pressure.
You get a better IDE ratio, standard IDE ratio.
Yeah, you can have a extended IDE ratio and still have the patient comfortable on the ventilator because they're able to initiate at that time high. If you have a long inspiratory time in a volume control mode, you're going to see a lot of asynchrony.
More the time is spent during inspiration, more is the mean airway pressure and better is the oxygen ratio. You guys understand that, right? Normal IDE ratio is 1 to 3 to 4. That's physiological. More time do you spend during inspiration, higher is the mean airway pressure, higher is the oxygen ratio. Basic, very basic.
Yeah, and conventional ventilation where the IDE is 1 to 3, 1 to 4, your mean airway pressure is controlled by your expiratory pressure. And that's why going up or down on your PEEP tends to help oxygenation because it's driving your mean airway pressure if you're spending most of your time in expiration. If you start going into inverse ratio ventilation or APRV, then your mean airway pressure is controlled by your inspiratory pressure. And that's one of the, if you're trying to control that as your primary variable, your mean airway pressure, then being in a mode where you control the pressures and the IDE ratio will give you the most precise control of that.
One basic question. Why is that we set the FiO2 at the lowest level at 40? Why not get it down to 21?
We can go to 21, yeah.
We see everywhere
I agree with what Kapil is saying. A CT scan is great. You can get useful information just from a chest radiograph as well. If you see that there's a sort of dependent atelectasis pattern on a chest x-ray with low lung volumes and suspected atelectasis, that's somebody who is more likely to be recruitable. If you see somebody with a lobar collapse or a whole lung collapse from a lobar pneumonia or from a mucus plug, then they're less likely to be recruitable, and they may need a therapeutic bronchoscopy. I agree not to do a bronchoscopy to get samples, but you may need a therapeutic in certain situations. And sometimes you'll see that somebody is grossly hyperinflated already, that their lung volumes are large, their diaphragms are flattened, and they're unlikely to respond to further increases. Sometimes you'll see the opposite. So sometimes you'll get the x-ray and see, oh, the endotracheal tube is in the main stem bronchus. That's the problem that I need to fix. So when I get these outside hospital patients, before I do anything aggressive with the ventilator, I always get some imaging first, CT if possible, but more commonly an X-ray, so I know what I'm starting with, and if there's something suggestive of what change in settings they may benefit from.
How low in the, when you dry out the lungs, how much do you restrict, maximum can you restrict the fluids?
Dry out the lung?
Fluid restriction.
Yeah, so my attending, his name was Mitch Levy, he was the president of the Society of Critical Care Medicine 100 years ago. So he used to tell me, keep the sodium 145. You want to keep them on the drier side. And I'm going to talk a little bit about fluid strategy. You want to keep them dry. It's a challenge, Deepak, it's TBI patients, right? You want to keep the sodium high, which is okay, but you want to keep the intravascular volumes reasonable to get your cerebral perfusion pressure. But there are no magic bullets. You have to be cognizant. So we get a lot of patients after 7-10 days of being sick at an outside hospital. By the time they come to our hospital, they are 18 liters off. So we put them on a Lasix strip. There it is, and I make sure you explain to the residents and the fellows that if you think the management of ARDS is purely Lasix, then by definition it's not ARDS. It's congestive heart failure. It's not failure. But unfortunately, you have to be cognizant about the volume that you have been giving. These sometimes smaller hospitals, they are indiscriminate 18 liters. So we dry them out and they get better. So, all right.
So going through the ARDS algorithm, the next thing we already talked about briefly before was the APRV, airway pressure release ventilation, which we can use to improve oxygenation and also have reduced sedation. Theoretically, we apply a higher mean airway pressure with a lower peak and plateau pressure compared to other modes of ventilation to show improvement in oxygenation. Once again, as a review from the previous slides, we improve oxygenation by increasing mean airway pressure, recruiting atelectatic lung units, and then allowing permissive hypercapnia. Another graphic showing on a different ventilator how the patient should look with their pressure time waveforms. We have our inspiratory time, which is very long, our very short expiratory time, and then another long inspiratory time. And the patient, you can see, is taking little breaths on top of that time high to get rid of some of the CO2. You'll notice during the exhalation, it's not returning down to baseline, and so we are generating auto PEEP, like we talked about previously. Another aspect of our ARDS algorithm is using inhaled nitric oxide. Now, this has not been proven to show mortality benefit in ARDS, but when somebody's severely hypoxic, this is something that we use in the meantime to hopefully improve their oxygenation. Inhaled gas that can be given to ventilated or non-ventilated patients. It is a selective pulmonary vasodilator, improves blood flow to the lungs, and can improve oxygenation in ARDS patients. It has a short half-life of about 60 seconds, and so as soon as we get it on a patient and turn it on, we should generally see an improvement if they are a responder. And then conversely, when we are weaning it off, and we are going from 1 part per million to 0 parts per million, we can see an immediate change in that aspect too.
Another question, I may add that it's one of the best, I know, the mortality benefit, because it goes where you want more perfusion. And that's
Yes.
the beauty of inhaled nitric
Yes.
oxide, is that you want to improve the VQ matching.
Ajay, the challenge is incredibly expensive.
Yes.
Every time I put somebody on nitric oxide, Jessica has to send a car.
Yeah.
And she walks home.
Every day.
It's incredibly expensive. And many hospitals don't allow inhaled nitric oxide.
Yeah, but I still love it.
So we do too.
So does Virgo.
Well, the important thing here is we use it for transport.
Right.
Yeah.
Sometimes we have such sick people and they do not have capabilities of cannulating somebody. They are smaller hospitals, they don't know ECMO, they cannot cannulate. So we use them for transport. So there is some data regarding, we have safety of transport when your pressures are really high. We recently, last week, we transported a patient 45 over 21, PO2 of 41, 48-year-old. What are you going to do? So we put him on some nitric oxide, got his PO2 up to 50. In that instance, they cannot candidates. He came and then promptly in about 45 minutes, I ended up candidating him for it. Because pressures are so high, we tried to reduce the mean airway pressure and he prompt. His saturations were between 60 and 70. So you don't need to measure the CO2.
And I also think, you know, the problem with it being expensive, it's not FDA approved for adult use.
Correct.
Is the issue that we have.
No, it's not. The only approval is for essential or plexiform pulmonary angiopathy, seeing the pulmonary hypertension in infancy.
Yeah.
Only FDA approval. We use a lot of things that are not FDA approved.
Other indications are cardiothoracic surgical patients with significant pulmonary hypertension, and so this is commonly used for heart or lung transplant patients, patients using a cardiac assist device, or just undergoing cardiac surgery with that history of pulmonary hypertension. Sometimes we'll use it for non-surgical cardiac patients with significant pulmonary hypertension, especially if they're already receiving other IV pulmonary vasodilators like at-home epoprostenol. And so since nitric is so expensive, there are other alternatives that we use like Iloprost, Flolan, or Velitri, which are all brand names for inhaled epoprostenol. And so our institution has been trying to go more towards using the inhaled Velitri. Now it's hard to get the culture changed because people do really love nitric oxide.
Well, we don't use it in ARDS patients because of the disconnecting of the ventilator with changing with changed filters when we use Velitri, so we prefer when we use it on ARDS patients to stay on nitric. And the hope is to get it off quicker than that.
Long-term therapy with sildenafil or tenofovir is another alternative, right?
Yeah.
Then there's the last part of our ARDS algorithm, which we'll go into much more depth later in the sessions, is ECMO, which is an advanced form of life support. We have a picture there of one of our devices. It consists of a pump with an oxygenator that replaces the function of the heart and lungs, and it gives the patient's heart and lungs time to recover, or as a bridge to transplant. So just put up here in general the ELSO general guidelines of which patients should get ECMO, the indications, which we'll go more in depth with Steve's lecture. Just to keep in mind, it will not benefit every patient with ARDS, and little is known about the long-term outcomes of ECMO. And so selection should be focused on patients who are most likely to benefit. Patients with reverse etiologies, early ARDS, so less than 7 days, and then few risk factors for futility. Need to be selective with who goes on. This is just a summary slide of the key elements of the ARDSNet strategy, which we talked about at the beginning. These are really the only evidence-based outlines for ARDS mechanical ventilation. We want to target that tidal volume of 6 mLs per kg ideal body weight, limit the plateau pressure to 30, allow plateau pressure greater than 30 in certain circumstances like a pH that's less than 715 and a respiratory rate at 35, PaO2 less than 55 with a tidal volume of 4 mLs per kg and FiO2 of 100%. And we can increase the tidal volume to 7 or 8 for double triggering. Provided that the PEEP plateau limit is maintained, we can set our PEEP and FiO2 per the table recommendations, so either that low FiO2 high PEEP or high PEEP low FiO2. PaO2 of 55 to 80, SpO2 of 88 to 95%, and then IDE ratios up to 1 to 1.
You see that? She did not mention inverse ratio ventilation. There is zero data to say inverse ratio ventilation